Welcome back. Today we're going to talk about Chapter 14, Psychological Disorders, which is our final chapter for the semester. Psychopathology, or abnormal behavior, can be defined as a sickness or disorder of the mind. However, this is not as clear-cut as it might at first seem. How much of a problem does something have to be before we consider a disorder? In general, in the United States, we use the DSM-5, which defines a psychological disorder as something that disrupts someone's life or causes significant distress over a long period. Even within those terms, there is, of course, a good deal of judgment involved. On the right, we see a chart listing some of the major psychological disorders. Some of these, as are seen with the blue lines, are more common in men. Some are more common in women, as are seen with the green lines, and some are equally common in men and women. Let's look at some of the criteria that have been used to define mental disorders in the past. First, does it deviate from cultural norms or what is considered acceptable in a society? This criterion has a number of problems, including that what behavior is acceptable in one society may be totally inappropriate in another. The second criterion, is it maladaptive? Maladaptive behavior is not necessarily a mental disorder. We all do things all the time that are not so good for us. Third criterion is, does it cause the person to have distress, or does it threaten other people? How much distress counts as enough for a mental disorder? That's somewhat of an open question. And many behaviors which are threatening or dangerous to others are not considered to be mental disorder. Finally, and I think the most controversial and least useful of the criteria is, does this behavior cause discomfort to others? Behavior which is distressing to others, but not to the individual exhibiting it, does not necessarily count as some sort of pathology. The pathology, in fact, may be in the observer rather than the actor. When psychologists seek to explain and study a particular disorder, there are four things that are important to us. One is the etiology, what caused the disorder. Next is the symptoms in the disorder. Third, are these symptoms consistent with the pattern that one sees in a particular disorder? Last, but certainly not least, is to identify possible treatments. People have observed unusual or distressing behavior in others for thousands of years. Here we see an anthropologist studying skulls, all of which have a small hole drilled or broken into them. This is due to a practice called trephining, which was practiced as early as 7000 BC and has been seen everywhere throughout the world at some point. The idea was that the person's aberrant behavior was caused by evil spirits, and that drilling a hole in the skull would allow the evil spirits to escape. This reflected some understanding that the brain, or at least the head, was the source of mental disorders and symptoms. Throughout history, the explanations for psychopathology have changed a great deal. Hippocrates, the ancient Greek physician, believed that mental disorders were, like other physical disorders, due to an imbalance of four humors. During the Middle Ages, again, behaviors were seen to be due to possession by demons or evil spirits, harking back to the times of the Trephining. Treatments were designed to drive the demon from the body and included exorcisms, starving, and beating the devil out of them. In some cases, people were actually executed for the purpose of saving their souls while destroying the body. During the Renaissance, once again, physical treatments came back into favor. Unfortunately, this renaissance of understanding did not extend to everywhere in the world and was short-lived as well. Up until the 1950s, in the United States, most patients with mental disorders were institutionalized in psychiatric hospitals, which were little advanced from the time of centuries before. Starting in the late 1950s, there was a movement to reduce the number of people in mental hospitals by treating them in the community. This movement started with the introduction of the drug Thorazine for the treatment of schizophrenia. The idea was that community mental health centers would provide the same treatments in the community. However, the implementation of the idea left much to be desired. And today, there are far too few psychiatric beds for those that need them, leading to people being boarded in emergency rooms or taken into the criminal justice system. The decline in the number of inpatient psychiatric beds corresponds to a similar increase in the number of jail and prison inmates. There are two major ways that people conceptualize mental disorders. One is the diathesis stress model, which suggests that people have a vulnerability to a particular psychological disorder, and that under stressful circumstances, this vulnerability will be expressed as the disorder occurring. The second model is the biopsychosocial approach, which says that there are biological, psychological, and sociocultural factors involved in determining risk for any particular mental disorder. Mental health professionals conduct an assessment of new patients in order to determine the correct diagnosis and treatment and to suggest a possible prognosis or outcome for that treatment. Assessments usually contain several parts, including an interview, people's self-reports, observation of the patient, and sometimes psychological testing is seen here. The most commonly used diagnostic system in the United States and Western Europe is the Diagnostic and Statistical Manual, or DSM-5. The DSM has 3 sections, including an introduction, the diagnostic criteria, and in the back, a guide for future psychopathology research that describes conditions that are not currently recognized as disorders, but might be in the future. One of the key characteristics of the DSM is that it approaches diagnosis as a dimensional approach. Mental disorders are considered to be along a continuum in which people have either milder or more serious symptoms. Let's look at some specific categories of disorders. Anxiety disorders are a class of disorders in which the prominent symptom is excessive anxiety that exceeds the actual danger in the situation. People who experience anxiety disorders tend to perceive ambiguous situations as being more dangerous than they actually are. There are several types of anxiety disorders, and I'll talk about a couple of them here. Specific phobias are fairly common, affecting as many as 1 out of every 8 individuals. These involve a fear of a specific object or situation that is out of proportion to the actual threat. Common phobias involve medical procedures, heights, water, closed spaces, or animals and insects. Social anxiety disorder, which is also called social phobia, is the fear of being negatively evaluated by other people. This is usually manifest as a fear of public speaking. In contrast, generalized anxiety disorder is a diffuse state of anxiety that is not tied to a particular object, event, or person. People with generalized anxiety disorder often go years before they are correctly diagnosed and are worried about just about everything, just about all of the time. Persistent panic attacks are the defining characteristic of panic disorder. A panic attack is a sudden feeling of overwhelming fear, anxiety, palpitations, shortness of breath, difficulty in focusing, and a sense of impending doom. Agoraphobia means that an individual is fearful to leave their home or other safe space because they're concerned that they will have a panic attack. Over time, these people tend to become more and more restricted in their movements, and some of them are not able to leave their home at all. Anxiety disorders fit well into the biopsychosocial approach. People vary in terms of their vulnerability to these, and the specific disorder they develop depends on the experiences that they have. Obsessive compulsive disorder involves obsessions and compulsions. Obsessions are the recurrent, intrusive, unwanted thoughts and mental images. People do not want to think about these things, but they cannot stop their mind from going there. This often includes worry about contamination, germs, aggression, accidents happening to people that we care about, or concerns about orderliness. Compulsions are the repetitive, ritualistic actions that people engage in that reduce the anxiety. By engaging in the compulsion, the anxiety is reduced, and so the compulsive behavior is actually rewarded, negatively reinforced, by the compulsion. Post-traumatic stress disorder is a reaction to a life-threatening or dangerous situation in which people develop a syndrome of symptoms including frequent nightmares or flashbacks related to the trauma, intrusive thoughts, an exaggerated startle response, and emotional numbing. Related to this, but milder, are adjustment disorders, when people have excessive difficulty adjusting to some change in their current life circumstances. Depressive disorders are disorders of feeling or mood. And there are two major ones. There's major depressive disorder and persistent depressive disorder. These two differ in terms of the severity and the length. Major depressive disorder requires symptoms lasting 2 weeks or more, Persistent depressive disorder requires that the symptoms last for at least 2 years. In major depressive disorder, people are extremely depressed, lose interest in normally pleasurable activities, have thoughts of hopelessness, helplessness, or even suicide, have difficulties concentrating, have disruptions of sleep and appetite, and typically have little energy. Persistent depressive disorder involves mild or moderately depressed moods that doesn't rise to the level of a major depressive episode. The mood should be sad or depressed more days than not in order to qualify for this diagnosis. It is possible to have both of these conditions at the same time, a condition called double depression, which is illustrated here. Seasonal affective disorder is a depressive disorder that occurs in a particular season, usually in the winter. And as you can see here, the further from the equator one is, the higher the risk of seasonal affective disorder. This suggests that the disorder is due to insufficient light. And in fact, the treatment, which is usually successful, involves exposing people to full spectrum light early in the morning for an hour. Depressive disorders certainly run in families, suggesting that there is a genetic component. And there are various brain areas that have disrupted function in these disorders, including the prefrontal cortex, the anterior cingulate cortex, and the amygdala and hippocampus. Psychological factors are also involved in depressive disorders, and some of the most effective psychotherapies target the particular types of thoughts that people with depression have. Social factors are involved as well. Across multiple countries and contexts, twice as many women as men are diagnosed with depression. One theory about this is that women respond to stressful events by internalizing their feelings, whereas men externalize their feelings. There are two types of bipolar disorder. In bipolar I disorder, individuals experience at least one episode of mania, which is characterized by pressured speech, lack of sleep, flighty, unconnected thoughts, and extreme amounts of energy. In bipolar II disorder, there is never an episode that meets all the criteria for mania, but people have what is known as hypomania, where they have a somewhat elevated mood, along with episodes of depression. Bipolar disorders are strongly heritable and tend to run in families, though there is no single gene that is involved in determining whether one has bipolar disorder or not. Schizophrenia is one of the most devastating of all psychological disorders. In this disorder, people have a break from reality in that their thoughts and perceptions are not grounded in the real world. This is known as psychosis. There is a combination of motor, cognitive, behavioral, and perceptual abnormalities in this disorder that are extremely debilitating. In order to meet the diagnosis, one must show continuous signs of these disturbances for at least 6 months. There are 5 major symptom categories for schizophrenia, and a person must show 2 or more of these, including one of the first 3, in order to meet the diagnosis. These can be further divided into positive and negative symptoms. Positive symptoms are excesses in functioning, such as the delusions and hallucinations. Negative symptoms are those that are marked by deficits in functioning. Apathy, blunted or flattened emotion, slowed speech, and reduced movement. Delusions are fixed, false, idiosyncratic belief systems based on incorrect inferences about reality. These are a symptom of thought disorder. Hallucinations can be defined as perception without sensation. That is, the individual perceives some stimulus and the stimulus is not there. On the right, we see a number of drawings by the English artist Lewis Wayne as his schizophrenia progressed. Disorganized speech is that which is incoherent and fails to follow a normal conversational structure. It's very difficult to follow this, as people with disorganized speech frequently change topics and sometimes even engage in clang associations where the words are related by sound rather than meaning. Disorganized behavior is very common in persons with schizophrenia, and they tend not to take very good care of themselves, not bathing or dressing appropriately for the weather, and sometimes act in strange ways. Negative symptoms, which are more common in males with the disorder, are associated with a poorer prognosis. These include avoiding eye contact, blunting or flattening of emotion, slowed speech, monotone tone of voice, long pauses before answering, and failure to respond to questions. Schizophrenia does run in families, and the odds of an individual having it depend on how many close relatives they have with the disorder. In identical twins, if one twin has it, there's about a 50% chance that the other will as well, which means there's about a 50% chance that the other will not. A number of theories have been proposed for how schizophrenia develops, including reductions in brain tissue. We can see here the individual on the right has larger ventricles than the individual on the left, and correspondingly, the individual on the right is the one with schizophrenia. Environmental factors are also important in the development of schizophrenia. Individuals who have a genetic risk for the disorder are more likely to develop symptoms in stressful environments. Personality disorders are maladaptive ways of dealing with the world that are characterized by inflexible, extreme behavior. We'll talk about a couple of them here. Borderline personality disorder is characterized by instability of mood, impulse control, and sometimes identity. Individuals with this disorder frequently fear abandonment by persons close to them. Antisocial personality disorder, sometimes known as psychopathy or sociopathy, is characterized by lack of guilt or remorse, a failure to follow rules, and seeing other people simply as a means to meet their own needs. These individuals are often superficially charming and rational, but they lack the ability to form close emotional connections with others. Dissociative disorders are a class of disorders that involve disruptions of identity, memory, or awareness. In dissociative amnesia, an individual loses memory for personal facts or sometimes even all events that occur within a particular period of time, and there is no apparent physical trauma that would have caused this. A subtype that is extremely rare is called dissociative fugue, in which people not only have amnesia, but travel to a different location and sometimes assume a totally new identity without any awareness of doing so. Dissociative identity disorder, which used to be called multiple personality disorder, is a very rare disorder involving individuals who have two or more distinct identities. On the right, we see signatures and writing from an individual with 6 separate identities. These were all written by the same person. While most mental disorders initially occur in late adolescence to early adulthood, some are more commonly seen in children. We call these neurodevelopmental disorders. One of these is autism spectrum disorder, which is of varying severity and is characterized by deficits in social interaction, communication, and by restricted repetitive behavior or interest. There has been an increase in the incidence of autism in recent decades. Children with more severe forms of autism spectrum disorder often seem to be unaware of others and have limited or no speech. They may have a restricted set of interests and be very upset by any changes in their daily routine. Sometimes they engage in self-soothing behaviors such as rocking or hand flapping. The cause or causes of autism spectrum disorder are the subject of a great deal of research, and there is much information and misinformation about these. Another disorder first seen in childhood is attention deficit hyperactivity disorder, or ADHD. There are 3 types of ADHD. The most common is the combined presentation, in which individuals meet the criteria for both inattentional symptoms and hyperactivity impulsivity symptoms for at least 6 months. The other 2 subtypes are the predominantly inattentive presentation and the predominantly hyperactive impulsive presentation. Inattentive symptoms include an inability to stay on task and difficulties organizing work. Hyperactive impulsive symptoms include fidgeting, leaving your seat in the classroom, running or climbing on situations where it's inappropriate, and an excessive amount of energy. About half of individuals will maintain symptoms into adulthood. I hope you've enjoyed this lecture and this class. As always, please feel free to contact me anytime you have questions or concerns. I look forward to hearing from you. Take care.